Hello, in this video I'm going to be talking about special considerations when treating breast cancer in older women. And for the purposes of this video, older women refers to women 70 and over. Before I go on, I'd love to invite you to subscribe to our YouTube channel. We are always putting out new content, so there's always something new to watch. And if there's something you're interested in, you can drop a comment below, and we'll probably make a video based on your suggestion. So breast cancer in older women, it's really important to understand that this video is not about less treatment or under treatment, heaven forbid, but rather about strategic treatment. And as part of a whole movement towards de-escalation or less treatment in everybody, studies have been done in older women with favorable, in quotes, tumors that are estrogen receptor positive and smaller. And it's been found that in a randomized controlled trial, such people do not need to have a sentinel lymph node assessment if the lymph nodes are clinically negative. So people over 70 with clinically negative lymph nodes, and what that means is we don't feel any enlarged nodes and we don't see any abnormal nodes on an ultrasound or a mammogram. Those lymph nodes are clinically negative, that means, with estrogen receptor positive tumors and smaller tumors, that we can omit a sentinel lymph node biopsy. Now, if somebody has palpable lymph nodes, we're not going to omit the sentinel lymph node biopsy, regardless of somebody's age. We like to assess and clear any positive lymph nodes. So this is something we know because people participated in clinical trials and people were randomly assigned to have a sentinel lymph node assessment and all the treatment that would follow versus no sentinel lymph node assessment, and the outcomes were no worse for people over 70 with the tumors I just described. In terms of other surgery, now we do tend to lean towards lumpectomy. As you know from watching our videos, it's just as good as mastectomy and quality of life tends to be better as long as somebody can have radiation therapy. Now there are some people who are older, and it actually doesn't matter your age. If you have mobility problems and you have a difficult time getting up on the radiation therapy table or lying flat for any length of time, radiation therapy might not be in your best interest. And so in that person, depending on the other characteristics, a mastectomy, removal of the whole breast so that no radiation therapy is needed, is an option. Now this is the case regardless of how old you are, but we're focusing specifically on people 70 and over. Now I've mentioned things like mobility problems. It's also important to know as we get older, we get more comorbid illnesses. So that's not true for everybody. There are lots of people who are 90 who are fit as a fiddle, and lots of people in their 40s and 50s with lots of medical problems. But let's say you're 70 and you have diabetes and you've had a stroke and you have heart disease, we may want to give less rather than more therapy. That's not because we don't want you to get good treatment. It's because we want to balance quality of life and quantity of treatment. The other things we consider are something called frailty. Frailty is sort of your get up and go. It's really hard to see from a medical record if somebody is frail unless it's been documented by the medical team. Frailty is sort of how robust are you? And if you're more frail, giving you more treatment is just going to give you the burdens of treatment without the benefits. And certainly in somebody with a limited life expectancy, where their life expectancy is less than 10 years, which is not necessarily the case if you're 70, but maybe the case if you're 90, giving you adjuvant treatments, extra treatments after surgery, you're not likely to reap the benefits of those. We view those as long-term benefits. All right, so we've talked about the things we consider. Of course, we consider the tumor biology, and I'll talk a bit more about that in a moment when I get to chemotherapy. I did want to talk about omission of radiation therapy. So just a moment ago I mentioned after lumpectomy we do radiation therapy, but are there people who can have a lumpectomy and not have radiation therapy? Now we have data from randomized controlled trials that yes, indeed, radiation can be omitted in somebody with a small hormone receptor positive tumor who plans to take endocrine therapy. They are willing and able to take an aromatase inhibitor or to take tamoxifen. They are no more likely to have impact on their survival if radiation therapy is omitted, and should they get a recurrence, it's treatable at that time with radiation therapy. So we've talked about omission of sentinel lymph node assessment. We've talked about omission of radiation therapy, either because somebody can't tolerate it, in which case we would do a mastectomy, or if somebody has a tumor that is histologically favorable. Again, I'm going to put that in quotes because I don't think there's any good tumor, but if the characteristics are such that the tumor is more indolent, more sleepy, more slow growing, we can be a little less thorough in the treatment. Now, somebody really has to have a tumor that meets all these criteria. This is not based on age alone. It's based on biology and preferences and you having full informed consent. Again, it's not about less treatment, it's about strategic treatment. If you are wondering if your medications in the treatment of breast cancer are likely to cause any of these problems, I'd love to invite you to go to Yerbba.com to get your personalized Yerbba report. Your Yerbba report takes your medical records after you give us permission or upload them. If you live in other parts of the world besides the US, you can now upload your medical records. Takes all of that information, creates a report saying everything we know about your tumor, everything about the treatments you've already had, cross-references that with the latest medical evidence, and then tells you your treatment options, what you might hear about or read about, whether or not this might be offered to you when you go to see your medical team, and the pros and cons of each. So this is a really helpful way to understand what experiences you might have if you're starting a new medication or starting on your breast cancer story. Now we know from a study by Reagan and colleagues that we can also give just Herceptin, which is the brand name for HER2-targeted therapy, or some of the biosimilars for Herceptin in people whose tumor is HER2 positive and omit chemotherapy. That's especially appealing if the tumor is also estrogen receptor positive, and we can give endocrine therapy as well. So I just mentioned chemotherapy. When is chemotherapy the right thing in an older person? Well, it's the right thing if it's going to improve somebody's survival over the next 5 to 10 years. And that's based on tumor biology as well as other medical problems. So if the tumor is not responsive to hormonal therapy, we're not going to give hormonal therapy. And if the tumor is big enough and is at high enough risk of recurrence, we're going to offer chemotherapy. But chemotherapy can be given as a single agent, such as paclitaxel, or if the tumor is HER2 positive, it can be the case that somebody would get paclitaxel and trastuzumab. And that's the case for you no matter your age, if the lymph nodes are negative and the tumor is small. So I've covered a lot today. I'd like to just end with endocrine therapy. Endocrine therapy is offered to every person with a tumor that's estrogen and or progesterone receptor positive. That's the standard of care. We know that endocrine therapy reduces the risk of the cancer coming back in the same breast and elsewhere in the body. You will see oncologists reaching more for the aromatase inhibitors than tamoxifen, and the main reason for that is that tamoxifen is associated with a higher risk of blood clots, which also increase with age. If you have no other risk factors, and if you don't tolerate an aromatase inhibitor, or if you're very worried about your bone mineral density, let's say you have osteoporosis, then tamoxifen would be an option. And you can also split that 5 years of endocrine therapy between tamoxifen and an aromatase inhibitor. I have covered a lot in this video. I hope it's been helpful. Drop a comment or a question below if you have one. We get back to you as soon as we can, within 1 to 2, and we've had so many comments lately. It's taking us sometimes 3 weeks to get back, but we will get back to you. We don't curate the comments at all. Thank you as always for watching, and we'll see you next time.